So, welcome back. Today we'll be making a video on neurological examination. So, neurological examination, I'm just going to talk about sort of clinical signs that we look out for that can give an idea into how the neurological system is functioning in the body. So, we're starting off with talking about the awake patient and then briefly about comatose patients. So initially, you can really gauge a lot of details just from having a look at from general observation. So one thing I do is just having a look for any scars in their head or spine for any previous surgeries. If a patient's got a shunt in, I try to follow the shunt, see if there's any breakages or any erosions or any issues of the shunt that you can see from externally. And then there's sort of clinical signs that can jump out at you. So I've listed a few that we might encounter. So Horner's sign, so that's demonstrated in this picture right in the left top hand corner. So you can see that one pupil is lower than the other one, the eyelid, sorry, and the pupil itself is also smaller than the other one as well. Probably not shown in this picture, but this patient's probably has got decreased sweating on half of his face. So Horner signs a disruption of the sympathetic innervation to that side of his face. And there's a variety of reasons for which that could be a reason. Another one's facial droop. So you can see in this picture, he's probably been asked to give us a big grin and raise his eyebrows up. But on the right hand side of his body, there's no crease lines. You can see there's a facial droop or asymmetry. And again, a lot of different causes that can cause it, including a lot of neurological conditions. Another thing is abnormal movement. So, is there any involuntary or voluntary abnormal movements that can be noted? And then sort of gross um, features on their appearance. So some things like pituitary tumors can secrete a lot of hormones sometimes. Cushing disease is one example, and Cushing's disease is an elevated cortisol level. And this can show up in many different ways. So here's a picture of someone with cushingoid features. So you can see fat pads in the back of the neck. You might call it buffalo hump, flushed cheeks. You can see their abdomen and their waist circumference is quite large, whilst having relatively skinny arms and legs. Um, so all these are sort of subtle features. Another thing I like to do is just testing their mental function. Most briefest thing that I usually do is just check their orientations. I ask them, what's your name? Where are we? Tell me the day of the week, date, month, and year. And that tells me a good idea of how oriented they are. There are other higher order cognitive function tests, usually conducted by occupational therapists, but we should be able to do them as well. So just testing different aspects of their brain, so their frontal, parietal, and occipital. Next thing I wanted to jump into was the cranial nerve exam. So, what is the cranial nerves? So, cranial nerves are, I guess, extensions of the central nervous system. They're central nervous nerves that supply the head and neck as well. Um, so, in regards to their functions, there's a variety of different functions and ranging from sensory and motor. And there's different ways to test. There's 12 of them in theory, and we'll go through each one. So we start off with cranial nerve one. So that's the olfactory, sorry, and that's responsible for smell. So it's rarely dysfunctional. So if there's a orbitofrontal meningioma or a fracture involving the plate that can disrupt the cranial nerve. It can result in a lack of smell. One thing I do is just try to use a pinch of coffee or very strong smell to help test the function of that. Number two is the optic nerve, responsible for our vision. One way is testing the visual acuity, so using a Snellen's chart. Visual field's another one. So here on that top corner, I've put a visual field. Everyone's got this little defect, a blind spot as we call it. That's where the optic nerve comes in from. And I usually use like a red pin to try to map out the different areas of their vision to see if anything's lost. Cranial nerve 3, oculomotor, trochlea, and abducens nerve, all are responsible for our eye movement. So you can see 3, 6, 4, representing all the different muscles that it innervates, and it's responsible for all our eye movement. So I usually get the patient to just follow my finger in all directions to see if there's any, if there's intact function in all direction. Um, this is also a great time to check for the pupil reflex. So if you shine a light into each pupil, it should constrict. And if there's dilation or lack of constriction, then that can signify a disease pathology. Next thing is cranial nerve 5, trigeminal nerve. It's responsible for our facial sensation. It's distributed into 3 different sub branches, V1, 2, and 3. I usually get light touch or pinprick to try to map out the different facial sensation. It does have a motor component that supplies some of our jaw chewing muscles. So I try to get them to open the jaw against my hand, try to test the strength there. Next is the facial nerve, cranial nerve 7. Again, it can result in facial droop if it's injured. And then the vestibular cochlear nerve, cranial nerve 8, that's responsible for our balance and hearing. Cranial nerve 9, 10, 11, and 12. So I'll start off with glossopharyngeal. So that supplies a lot of our sensation in the back of our throat and our pharynx. Cranial nerve 10 is our vagus nerve. So again, that is responsible for all our rest and digest, and also responsible for our gag reflex. So testing the gag reflex will test both nerves simultaneously. It also is responsible for our palate. So you can see that on the top corner, you can see that the uvula is deviated to one side. So it shows that this side's working well, lifting it up when you get someone to say ah, but this side it's failing to do so. So it shows that there's some weakness, possibly from a vagal nerve palsy. Cranial nerve 11, the accessory nerve supplies some of our shoulder muscles, sternocleidomastoid and trapezius. So I try to get the patient to shrug their shoulders up and turn their head to one side to try to test that function. The last one, hypoglossal, is responsible for our tongue movement. So here you can see that this tongue side of the tongue shriveled up. This side's working well, pushing it to one side, but this one's pretty weak. So I'm suspecting that you probably ask this patient to just poke their tongue out straight, but you can see that they're not able to do that, possibly from a left-sided hypoglossal nerve problem. Motor system. So before I go into it, motor system is controlled by different aspects of the brain. So we got our prefrontal cortex and the cerebral hemisphere, and then the cortical spinal tract that goes down our spine. So if there's any injury along from the cerebral hemisphere, all the way down into the spinal cord, into our peripheral lesions, it can all cause issues with our motor system. So we grade motor strength by 0 to 5. So 0 having no movement. 1 means they've got flickers of movement in their hand or legs. 2 meaning they can move it but just can't defy gravity. 3 is they're lifting it above gravity. So if you ask them to lift it up, they're able to lift it up. 4 is that they're able to lift it up well, but it's just reduced power. And 5 is full strength. And then sensation, I always check sensation according to the dermatome map. So you can see our whole body is supplied by a series of dermatomes. So corresponding to each level can signify a different problem. And I usually use light touch, pain, temperature, and joint position. And these are all, try to cover all aspects of sensation. In terms of the motor movements, different aspects of movements can correlate to different levels of injuries. If someone's unable to lift their ankle up, I'm suspecting a pathology at this level, so for 5, and I'll look at the scans and try to find out what's causing it. Then there are other motor aspects that can control movement. So cerebellum is involved with our coordination. So I get the patient to usually touch their finger and to their nose and back to my finger and go back and forth, and then try to rub their heel to their shin back down to their foot as fast as they can. And that can really signify if there's any tremors or incoordination to pick up on. Gaits, very important. So I get the patient to just walk one end of the room to the other. And different pathologies in neurology can demonstrate different gaits. So if someone has a hemiplegic gait, they'll be usually swinging their legs, circumducting. If they have a shuffling movement, they're a stooped posture, and their magnetic sort of gait, it can signify Parkinson's disease. If they're broad based, if their gait is quite broad and they're relying, maybe perhaps leaning to one side, it could suggest a cerebellar issue. So again, there are many different pathologies that can cause gait disturbances. And then finally, in a patient that has a decreased level of consciousness, or someone's not talking to you, they're quite comatose, then GCS is a very important scale. So GCS stands for Glasgow Coma Scale. We grade it by giving it an I score, a verbal score, and a motor score. So I split up into 1 to 4. So if someone is normal, they'll be talking spontaneously. In their verbal score, they'll be oriented to the time, person, and place. And in their motor score, they'll be obeying commands very well. So they score 15. Meanwhile, an inanimate object, so if someone is like, I don't know, an inanimate object, like a book, there'll be no response to the eye opening. So even if you give them pain, if you put pain onto their body, they're not able to open their eyes. They're not able to make any verbal response to pain or any response at all, or motor response. So even to pain, there is no response at all. And again, it can vary depending on the degree of level of consciousness. Pupils is a good thing to check. So if there's dilation of pupils, we're worried about increased pressure within the brain or herniation syndromes. And then motor function, just testing if they've got any sort of movement in any of their forelimbs. In terms of pupils, quite important. I think I've been taught that, especially in a comatose patient, a pupil and looking into their eye is sort of like a window into their body, into their brain. So it's important to assess that. So I think that concludes this topic on neurological exam. Let me know any thoughts of any future videos that you wanna see, and I'll see you guys in the next video. Ciao.